So today we have Dr. Marian Evett from the Atlanta VA. Dr. Evett is a movement disorders neurologist here at the VA. So very excited to have you here with us today. We also have Mike. Mike is a veteran currently living with Parkinson's, as well as Jerry. Jerry's also a veteran with Parkinson's. So I don't know where you guys are going to be the most comfortable, but you can certainly stay where you are if that's easier for you. And then Dr. Evett, if you and Jerry want to, you can certainly stay up here, or you can kind of come stand up here at the front. So we're just going to have kind of a relaxed Q&A for the rest of our time during this first session. The goal is really, again, to hear from Dr. Evett, who's, if those of you who are not familiar with what a movement disorder specialist is, it's basically a Parkinson's expert. It's a neurologist that's done an additional fellowship in movement disorders, which Parkinson's is a movement disorder. So, all right, and then of course we have the two experts, the two who are living with Parkinson's. So I'm gonna just kick things off. I'm gonna start asking each of you guys some questions, if that works, and then if you guys have questions in the audience, we'll certainly take some of those in just a few minutes. All right, so I'm gonna start with Jerry and Mike. Oh, thank you. So Jerry and Mike, first question for you guys is, when and where did you both serve? If you don't mind letting folks know where you served.
I served in the Marine Corps in the mid 80s. I was at Camp Lejeune.
And then Jerry?
I was Army Infantry, 76, 77 at Schofield Barracks, 25th Infantry Division.
All right, so now I'm going to talk a little bit about, first of all, thank you both so much for your service again. So Mike, I know you were stationed at Camp Lejeune. So was your Parkinson's diagnosis a direct result of your time there?
Yeah, that's what we surmised. It was a result of my time and the contaminated water. You have to excuse me, my voice is really, really low sometimes.
And I know you had mentioned that your wife, Angela, some time had gone by since you were stationed at Camp Lejeune, and it was your wife that noticed some of your earliest symptoms.
Well, yeah, 25 years after being at Camp Lejeune, my wife started to notice changes in me. It was actually 10 years ago. She just started noticing differences. And I'm kind of lucky because my wife likes to write. So she writes down everything. So when we went to the doctor, and they said it was neurological, what I was dealing with was possibly neurological. The doctor said, what have you witnessed? And she whipped out a book, and there it was. And I was like, I should have known. But, I mean, I didn't notice that things were changing. My wife did way before, and she would complain about, why are you walking like that? And I'm like, well, maybe I'm working out at the gym. I used to work out at the gym 6 days a week, 3 hours a day. And I was into powerlifting. So naturally, you're gonna tear muscles, and you're gonna have little aches and pains. So I equated that with my performance at the gym. But as time progressed, my range of motion began to lessen and lessen. And then my wife pulled me on through.
Got a good wife, a good note-taking wife over there. All right, Mike, well, thanks so much. And Jerry, your situation with Parkinson's, I know, was a little different in that your diagnosis was not service-connected. Do you have a family history of Parkinson's?
Not really, not to my knowledge. I looked into that, and certainly no one in my immediate or nuclear family, and as far as extended family, there is one person, a cousin of my dad's, but I'm planning to get some genetic testing done. So even though I don't believe there's a genetic link for me or genetic predisposition, I know that's in fact there are people who have that disposition. So yeah, I'm a service-connected disability, but it's not Parkinson's like Mike. My Parkinson's is not related to my service, although my care is here at the VA, and I'm very thankful for that. Um, it's not service connected.
Okay. And Jerry, what were some of your, I know we heard kind of what some the early things that, Angela and Mike noticed. What were some of your earliest symptoms that you can recall that?
Well, yeah, so for me, and I probably had it a couple of years before my diagnosis in 2014, was tremor. But some other non-noticeable things were happening. For example, I was having strange dreams about my handwriting. I'd often wake in the night, my hand would be moving because I was dreaming about writing. And in fact, my handwriting, like most people who have Parkinson's onset, was small and unrecognizable. And so there were subtle things like that. But I had a pretty dramatic day, the day of my diagnosis, when I had a complete panic attack. The world was upside down. I was totally off, paranoid. I couldn't, claustrophobic. I had to be outside walking around. I didn't know what was going on. I didn't understand any of it. I tried to go to work that day. I could not even think of sitting down at my desk and working. My brain was like not functioning properly. Ran to the doctor's office. What's going on? He immediately gave me something for my panic attack, and the neurologist came in and had me do a few things, and determined that it was probably Parkinson's, and so that was kind of the essence of the day I was diagnosed, and I have a left side only tremor, so I feel very fortunate, but these slides about the peaks and troughs was very enlightening for me, and I think that's one of the best explanations that I've seen that really makes it understandable. So.
All right, Dr. Evett, now I'm going to put you in the spotlight here. So in your work with veterans who have Parkinson's, do you notice that anxiety and depression seem to be a bit more prevalent in your veteran patients than in the general population?
I'm not sure that it's necessarily more prevalent, but and I say that because when the nervous system is involved, oftentimes anxiety and depression symptoms are very common. Certainly, we do see, for example, neurologists tend to focus on those motor wearing off. Is the tremor getting worse before your next dose of medication is due? Are your steps getting, instead of a good normal stride length, are they getting shorter and closer together? Is somebody's voice getting lower, their words running together? Similar to, I'm going to have to stop using this analogy soon, because our trainees have never seen Tim Conway and Carol Burnett show. Tim Conway used to do a skit, The Old Man, where he would have tremor and shuffling steps, and the new trainees weren't even born then. But oftentimes, along with that motor wearing off, where the symptoms reemerge before another dose during the day is due, you may also experience more anxiety, depression symptoms. So it's like a non-motor symptom wearing off phenomenon. And even in multiple sclerosis and ALS and some of the other conditions that we treat, you sometimes see that. So it's hard to say, is it more common than, if I were a GP seeing people coming in for their annual physical examination. But it's certainly something that we often struggle with. Are these symptoms that need more dopaminergic therapy, more medicines like carbidopa, levodopa, or is it endogenous depression unto itself? One thing that I think I've crossed the 30-year mark in working with patients with Parkinson's, and in the early days when I first returned to Emory to do my movement disorders fellowship, there was a very wise psychiatrist affiliated with the functional surgical program, pallidotomy in those days, and then subsequently DBS program at Emory. And he will often keep patients with Parkinson's on a very, very tiny dose of some of the medicines that are used to treat plain old depression, whether you have Parkinson's or not, because he's found that if somebody's treated, they function better, and you can lower the dose. If you take them off, sometimes that what would ordinarily be a homeopathic, call it placebo effect, whatever, but just that little drop, that dab of antidepressant or anti-anxiety medicine, they don't function as well and some of their symptoms recur. I'll stop there, but I do want to, you had mentioned, I think, Jerry, you didn't think there was a genetic component, and I think you had said that the Parkinson's Disease Foundation, PDF, is doing genetic testing. One of the things that our Atlanta VA is participating in is there is a nationwide study, what they call a GWAS study, Genome-Wide Association study, in patients with Parkinson's, specifically veterans, where I call it over-enrolling veterans who are of non-white, non-Western European descent, because virtually all of the studies that have found gene-environment interactions have been like 97% Western European white. And they've identified some things like caffeine and smoking, nicotine, and certain forms of various genes, that interaction, having a certain exposure level or lack of exposure, and having a particular form of a gene may increase or decrease one's risk of developing Parkinson's. Well, two things. One, there were very few veterans included in those studies. Two, we don't know, are those going to be applicable to veterans, to patients with Parkinson's who are of non-white, non-European descent. So to participate in that study, patients who are already enrolled in our clinic, when they come in for their visit, we are approaching them and saying, are you interested? But I think for veterans in general, it's also important because our veterans had exposures that the general population did not necessarily have. And so it is a golden opportunity to be able to get that information. And I think what I'm seeing more and more, I mean, the whole gene and gene-environment interaction research arena has exploded in the last few years. And I'm not sure whether the Gene PD is cooperating with the Vet PD study, but it's...
I'll find out, though.
Yeah. But at any rate, I think it is something to be, and I wouldn't necessarily dismiss the possibility of a gene-environment interaction. So, oops.
Is it blood test or spinal tap?
It's basically a blood test. So if we can't get blood, we can do a saliva swab, but you get it's a better sample for doing genome-wide testing from blood. So it's, we're trying to make it as incorporated as much as possible into when somebody's going to be here already so that they're not having to make an extra trip. We do realize that coming ITP, for those that live outside the perimeter, is a burden. So we're trying not to add to burden.
Like the ITP.
I just want to say that I am one of those patients that remains on an anxiety medication as a supplement to my carbidopa-levodopa. So, yeah, that definitely helps.
Yeah. And it's, for example, say somebody was started on, a common one might be, say, Paxil. Maybe they were treated with 20 milligrams at one point. They might wean the dose down to like 5 milligrams, which would ordinarily be too small of a dose to think that it's going to have any impact. But Bill McDonald, Dr. McDonald over at Emory is like, yeah, I don't like to take them off of it. And that's something that not necessarily a lot of mental health providers are aware of. And it's one of the challenges is it's incredibly difficult to get information about what might be the best treatment method for a patient with Parkinson's amongst the various subspecialties that end up treating them. And that's where I have to put a plug here in for PDF, because historically I have advised patients over the years that you guys have a great library and resource library, which on the one hand, you don't want to get compulsively like looking at everything and trying to hyperanalyze, but on the other hand, using the resources that PDF has as a library, and you may find yourselves educating your providers on, hey, this is what's coming up in the field. And I say mental health, it's also primary care, because we do a lot through primary care here at the VA.
Yeah, we actually just recently published a paper, and it was basically looking at how many people with Parkinson's using Medicare data are seen by a movement disorder specialist, and it was only 9% of all people with Parkinson's are seeing a movement disorder specialist. And then, the remaining population, it was basically split between general neurology and primary care physicians. So here in Atlanta, I feel like we're so fortunate because we do have access to experts and specialists. But yeah, there are a lot of people who are primarily seen by their family doctor.
Yeah, and I think the other challenge that our nation's facing is we just don't have enough neurologists. So that's where I know in our own neurology, we now have 4 nurse practitioners. Well, one of our challenges is not just keeping ourselves up to date on what's the best treatment, but educating our nurse practitioners, what they call APPs, advanced practice providers. Yeah, as I say, it's definitely attending sessions like this, I think, is incredibly important. But back to the topic at hand. Sorry for the derailment.
No. This is great. And going back to like the complexities of Parkinson's, I went to my mom's last neurology appointment, and if you have access to an expert, Parkinson's is so complex, especially as motor fluctuations start. My mom had this 10-year honeymoon phase, and then we went to this appointment, and she was like, "I'm having no on time," and so that we sat there for hours trying to figure out if there was a pattern, or if she gets more sleep or eats certain foods, would she have more on time? And so just the complexity of the medications and the dosing, I mean, if you have access to a specialist, I think it's definitely worth seeing one. So I'm going to kick things back over to Mike and Jerry. We're waiting patiently. So Mike, what has been, if you don't mind sharing, have you had any personal experiences with anxiety, depression, or apathy? Just kind of that lack of motivation.
Yeah, I've had some times where I've gotten not depression. Or, I'll tell you this: I have to disentangle apathy and depression. You have to make sure that you're not thinking of that they're the same. They're not the same. One doesn't lead into the other. Apathy-wise, I've experienced what I call being flat, where I have no emotion, no feeling towards whatever it have you. I mean, my wife, what are you going for dinner? I don't care. It's easy for her, but I hate liver. I've had, like Jerry said, I've woken up in the middle of the night and I don't know if hallucinations been going there. I felt a sense of urgency. And I felt it necessary to run through the house. Well, me running, to waddle through the house, looking for somebody that wasn't there, but I could just feel that person being there. And that's probably about the extent. Mm-hmm. I mean, I guess I have to equate it to my on and off time too, because when I'm on, I do relatively well, like I'm doing right this moment. But I have really bad days where it seems like everything goes afoul.
I have a question for both of you, Mike and Jerry, which is, in our veteran population, PTSD is incredibly common. And I think in past generations, we didn't recognize PTSD for what it is. And sometimes we joke about, okay, I tried X, Y, or Z, and there was such a reaction that now I'm not going to go there again. But in our veteran population, I know one of the things that I, as a provider, sometimes have difficulty distinguishing is the PTSD symptoms seem to be inextricably entwined in depression and anxiety symptoms. And so sometimes it's very difficult to figure out, should we push for more aggressive management of PTSD symptoms, or do they need to be managed as depression and anxiety? Or the treatments are often very similar, and it's hard to say which. So have y'all experienced, if you don't mind sharing, PTSD? Or if so, do you have any way of distinguishing between what's PTSD versus depression or anxiety? Because for our veteran population, I think that's a difficult symptom to be able to bring to your provider and help your provider tease out. Sorry if it's a long-winded question.
Well, I do want to ask this question first before I give any answers. Depression, anxiety, PTSD, they're not necessarily, PTSD is not necessarily mutually exclusive. It's not its own bucket. So I would think, in my mind, first of all, I don't believe that I have any PTSD related to my service. But I do believe that anybody in combat, I do believe that there are lots of individuals, veterans primarily, as the largest group of PTSD, not candidates, but people who suffer from that. Clearly, there's no question in my mind, and that's enough to make anybody depressed and anxious. So I think of it more as a cause, and the effect would be the depression and the anxiety. But I'm no MD or scientist, so I don't know how the community looks at it, but that's my personal opinion.
Ditto.
I will say, I personally see it as a continuum, and it's a little bit of a chicken and egg situation. One of the things that I find myself telling patients commonly is that people's Parkinson's symptoms end up being a barometer for their health otherwise. And that includes not just, is their diabetes under control? Are they exercising? Is their blood pressure under control? But also, if they have pre-existing PTSD, is that under control? And any kind, even self-limited illnesses, the flu, COVID, sinus infection, bladder infection, those are physiologic stressors which will amp up the severity of Parkinson's symptoms, whether they're non-motor symptoms like anxiety, depression, or whether they're motor symptoms. By the same token, if somebody, say they were a lifelong sufferer of depression or anxiety, and that ramped up, because usually the natural history is that it's not like, okay, it's really bad, you get it under control and it stays under control. You know, that's just not life, right? And so when it does ramp up, you may, I advise people that you may see your Parkinson's symptoms increasing, both motor and non-motor. And so that's often when people are coming to clinic, one of the things I'm asking is, how are they doing when you average out your good days, your bad days, and your in-between days, so that we get sort of a, we're going for here. We're not going for, if we go for suppressing all symptoms on a bad day, then we're likely over-treating, and we run the risk of increasing adverse events from medications or other treatments. But if somebody's got PTSD or other mental health issues, other medical issues, then a lot of times I'm encouraging people to keep those as optimally managed as possible. And you know, we know there are things, I find myself more and more recommending everything that we can do that's not stuffing a medicine in somebody's pill box, that helps manage their overall health, will help keep their Parkinson's symptoms, whether they're non-motor like depression and anxiety, or whether they're motor symptoms, as well controlled as possible. So things like exercise, massage therapy. If somebody has sleep disruption, if it's from obstructive sleep apnea, actually treating that can help. And we have, sleep apnea in our general population, forget Parkinson's, our general population is pretty rampant. And what I've seen in the last 10 or 15 years is people are recognizing that it needs to be treated. Where they sometimes can use some help is realizing that for depression and anxiety symptoms, if you have CPAP and it's not optimally managed, when I say optimally managed, I don't mean it's perfectly under control, right? But as best as it can be. Having sleep apnea that's undertreated or untreated can actually cause depression and anxiety symptoms in even somebody without Parkinson's. So it's a continual surveillance of all the different ways, and sometimes things happen. You know, my husband suffers with sleep apnea. He gets an upper respiratory infection and he can't wear the CPAP. Well, that's usually when I go in the other room and sleep. But, you know, things are going to happen where you're going to fall off the wagon. If you're exercising because exercise is one way of managing anxiety symptoms. So it may be, Mike, that when you're waking up and feeling that, I think there's somebody here, it may be that you've had some REM behavior disorder where that you're dreaming and you wake up out of a dream and it, it's right there and your heart's pounding. But moving around is one way. My kids, when they were coming through high school, they would get so anxious that they couldn't focus and study. I'd send them out to the driveway and run up and down the driveway because that physical activity was a way, without medications, of helping manage those anxiety symptoms. So hopefully, I know that was a long answer, but it all ends up getting wrapped in, and I think the takeaway message is that looking at everything you possibly can, because remember the nursery rhyme, the leg bone is connected to the hip bone, is connected to the backbone. In medicine, more and more, we are finding that everything impacts everything else, and you're often, whether you're a patient or a provider, you're faced with, okay, what's causing what? Well, sometimes there's no way of sorting it out. And so what you do is, just like if you were in battle, you're not going to put, okay, I'm mixing puns here, apologies, all your eggs in one basket. You're going to have multiple different strategies for winning that battle. So you want to try looking at, okay, how can I, here's what I have identified as an issue. I'm going to try to manage each of those things to the best of my ability.
And Jerry, do you mind sharing a little bit about your kind of personal experience?
Absolutely. I want to say, Dr. Evett, everything you're saying is like so right on. I mean, it resonates completely with me. I have to, I'll use the word struggle or challenge, but depression, anxiety, apathy, it's an everyday occurrence for me. It's an ongoing process where I have to overcome those otherwise negative things that are going to pull me down into a place I don't want to be. So regardless of all the chemistry, and I understand why I may not feel motivated, why I don't want to eat sometimes. I don't really care if I eat or not, but I know I have to. I certainly don't want to have to get out of bed and go to the gym. I'd much rather just turn over and go back to sleep, especially when I'm taking medicine that makes me sleepy. But you know what? Exactly. But I know that's not going to help me. So there's somewhere, even it's not about dopamine, it's about my higher self or my instinct or my being alive and that tells me you better eat and you better go to the gym and you better exercise and you better do this and that. So some things I can control, and I certainly have zero suicidal thoughts. Whether I'm depressed because I'm upset about how I feel or I don't have energy or I don't feel like doing this or that, it never gets to anything other than I got to fix it. I got to repair it. I have to correct it. So that's kind of my attitude, and my attitude is what motivates me because the dopamine isn't doing it anymore for me. So unlike people who have those natural rhythms, I've got to take mine out of a bottle every 3 hours, and I do, like clockwork. But yeah, it's an ongoing struggle, and I think the best advice I would give people is you've got to motivate yourself. You ultimately, that's the only way it's going to happen. And whatever you've got, work with that, because we all have different levels of severity. One of my care providers said, "You hit the lottery. You hit the Parkinson's lottery." And I look around me and I go to support groups and I understand what they're talking about. So I just want to do everything I can to help motivate others and have a positive attitude despite all of the horrible things. This is one of the most horrific diseases you ever want to get. I tell you that. It doesn't miss a thing. Head to toe, it's an unbelievable list of things that can go wrong. But despite that, there's treatments, there's therapies. Hopefully one day there'll be a cure. And that's what keeps me going. And people that I care about and love.
I would say if you need to have a motivator, something that you can look at right then and there and tell yourself, I need to push. I need to go for it, try hard. I actually enjoy working out. That was my thing. That's what I did. If you didn't see me, if I wasn't on my way to work, I was on my way to the gym. And since my diagnosis and the medication and whatnot, and I have these flat days where I don't feel like it, I've put into place where I see pictures of my grandkids, my grandson and granddaughter, and I tell myself, I need to push because I need to see them, and I push. And you need to just set yourself up for outside consistent motivation, and keep saying to yourself, I can't give up. I mean, Parkinson's, I say that every morning. You picked a good one this morning, Mr. Parkinson, because we got a fight going on.
And I think it's time to replace the Tim Conway shuffle for the younger people. Let's get Muhammad Ali on there going up to light the Olympic torch. Okay, they'll know that picture.
And actually, I'd like to reiterate what you both said about finding something that motivates you to go through those lifestyle measures of managing Parkinson's. And I've often counseled patients that what that motivation is going to be different from one person to the next. I remember I had one patient years ago who I was encouraging to do exercise regularly. Well, the patient signed up for a 3 times a week exercise class. And patient came back and said, okay, I'm tired before I go. I'm exhausted after I go to exercise. But you know, Doc, I've realized that the days I don't go, I'm twice as tired. So they saw the benefit of it. I had another patient who said they signed up for the class and paid money because they knew that they were damn sure they were going to get their money's worth out of the class. And that was the one thing that motivated them to go. So, different motivations, whether it's family, whether it's friends, whether it's okay, I know I can do this. Anything that works, I say, make it work.
Well, outside of exercise and these kind of like external motivators that you guys have identified, are there anything else, Jerry or Mike, that has been really just helpful as you kind of navigate, the highs and lows, like support groups? Or I know both of you have been very involved, I know with other organizations, I'm sure, but also very involved with the Parkinson's Foundation. So, how has things like, volunteering really, made a difference in your lives?
It's essential for me. It's my way to connect and reach out and get the help and give myself a reason for being every day. So, from a young age, I've always tried to be helpful and be of service to others. I go to support groups monthly. I'm an ambassador with the Parkinson's Foundation. I love to get out in front of people, veterans, anybody with Parkinson's, and just talk and just share. And there's a lot of good that comes out of that and that interaction. Annie and I see Ashley in the back from the foundation are unbelievable, dedicated young people who, for whatever reason motivates them, they're here for us. and they're incredible. So, yeah, it's like a commitment to myself to break through all of the things that would otherwise hold me back and keep me down, and that's how I manage to stay out of trouble, for the most part, with some of these things, because you know this is tough stuff. What we just heard about, the depression, the anxiety, apathy. It's you know, I'm sure that anyone with Parkinson's knows exactly what we're talking about, and their caretakers as well.
I've also had counseling sessions, and that helps a lot with as an outside motivator. But again, I hate to say it, but I got to go back to it. My wife motivates me more than anything else. She constantly reminds me that you said you're going to be here to take care of me. That's right. I need you. So get up and go. And that's enough.
In the box.
Are you with PD Gladiators?
Parkinson PD by
The Center for Movement Challenges in
Yeah.
Sandy Springs.
as you can tell, I'm a Rocky fan. I'm a Rocky fan. And I knew there was a problem when I started forgetting the words to the movies, the dialogue. I said, yeah, I got an issue now. I need to see it. I need to see somebody.
Well, I want to give you guys in the audience an opportunity. If you have any questions for any of our panelists, you can certainly raise your hand. Yep, okay.
I don't need a microphone.
Okay.
So I just wanted to make sure there's no mistake about this motivation conversation. Y'all are the motivators, right? Marines, Army, I'm retired Army. The one thread that runs through all of us in our service is leadership. And I don't care, Big Mike, if your voice doesn't project the way it used to, you're a doggone leader. Oh, by the way, you're a comedian, okay? So on your good days, you need to be up front making money, brother. But I will tell you this, I've had an opportunity to get to know Jerry a little bit, and that guy, I showed up today because of him, because I consider him to be a leader. And I'm not as old as he is, but I tell you what, and I say that respectfully, because he runs circles around me with motivation. And he motivates me. He motivates a lot of people that I've introduced him to. A lot. So just understand that this leadership thing, that ain't going anywhere. As long as you want to open your mouth. It starts with your wife, you, whoever we've got in our sphere of influence. So just know that you're the motivators, because you're up front. We're sitting here. We're looking at you. And that's something that is part of your DNA and will not leave until you take your last breath. So thank you very much.
Thank you.
A couple things. First, Mike, Jerry, thank you so much. Mike, Semper Fi to a fellow Marine. Question, has anybody looked into lifestyle choices, alcohol consumption, recreational drug use, and if it has any link to it? And I'd like to talk to you about the genetic testing, because I'm the second of 4 children, the oldest in the family of brother, the youngest in the family of brother. Both of them have Parkinson's, my sister and I, we don't. You know, is it waiting for me, or?
So repeat the first part of the question again.
Recreational drug use, alcohol consumption, anything like that?
So just making sure that the folks in the back can hear. Has anybody looked into recreational drug use, alcohol use, and Parkinson's? And there are some ties to some of, and sometimes it's a little difficult. For example, TBI is one of the environmental exposures that, in general, we think may increase somebody's risks of developing Parkinson's. Now, is that because the TBI sets off some sort of a domino chain of events? Because Parkinson's in general is thought of as a disease of aging, right? So that the cells in the brain that produce dopamine begin to die off at a faster rate than, I always say, we're losing brain cells every day, right? Is what the general consensus is, but at a faster rate than the rest of our brains. And certainly there are some conditions where I think it may be a gene environment. So somebody having a particular form of a gene and then having exposure. The difficulty, for example, with alcohol is that alcohol is specifically, it's a toxin. So your whole nervous system, people with diabetes, people with, if you have a neuropathy, say it's an inherited neuropathy, Charcot-Marie-Tooth, what the neuromuscular experts always taught us back when I was in neurology residency was that as little as 3 drinks a week may amplify the severity of the neuropathy symptoms. So teasing out, is the alcohol specifically poisoning, or high alcohol use specifically poisoning those dopamine producing brain cells, neurons? Or is it, okay, your health overall? People who drink more, who smoke more, they get COPD, they have lack of oxygen. So it's kind of that, one more straw on the camel's back, so to speak. There are some interesting things that people have looked at, for example, nicotine and coffee exposure. So if you have particular forms of some genes and you have a nicotine or a coffee exposure, it looks like, okay, might it be protective? To the point that people have thought about doing clinical trials to either slow down or symptomatically treat Parkinson's. Well, with caffeine, I mean, God, if I don't get my 2 cups in the morning, I can't string 2 sentences together. And usually about this time on Friday afternoon, best not to talk to me because I'm not going to be very eloquent. So people have looked at that. I think getting it down to a personalized level, so in an individual, we still have a little ways to go. We have a few more of the GWAS studies to look at. But do I think it's going to come in my professional lifetime? I wouldn't be surprised. The other thing that you're starting to see is when people do treatment trials, they're looking for specific genotypes and exposures potentially to enroll. And it's even started in the studies that we've been doing to try to figure out, well, what are the factors that we have control over that we might be able to impact, right? Genes right now, even though I know sickle cell gene therapy got approved this morning for kids 12 and over, right now I'm going to count genes as something you don't have easy ability to change. But the PARS study, where we looked at people who we knew had a first-degree relative with Parkinson's, and then we looked at their sense of smell, and then did they subsequently develop Parkinson's, have helped cement what we thought, things like constipation may be symptoms that come on years before somebody develops the motor symptoms of Parkinson's. So there's not an easy answer to the question as to have people looked at certain exposures. And then one of the things that, because we have a high percentage of our veteran patients here at the VA who need medications to treat Parkinson's. Some of those, PTSD, depression, anxiety, some of those drugs can cause somebody to look like they have Parkinson's. And so sometimes we see where that it's a little bit of both. They have some drug-induced Parkinsonism, and then they also have what we think is probably idiopathic Parkinson's disease or one of the related things like Lewy body, Parkinson's.
I have two questions. One, we talked about the personality sometimes of persons with PD. Has it been found that their previous personality affects at all their personality after they have Parkinson's? Like if they were very sweet and everything before, are they easier to handle later? Or if they were always angry, are they?
I don't know that I've ever seen a pre and post diagnosis predictive value. One thing to keep in mind is with that we're beginning to appreciate that there's probably this long prodrome where some of the non-motor symptoms may emerge as long as 20 years prior to when somebody receives the diagnosis, because the signs that you can see on exam are prominent enough that it, people often get mad. Somebody with Parkinson's walks into the room for their first appointment, and hopefully I've not done this, but I've had patients report that the doc looked at him for 30 seconds and said, "Oh, you have Parkinson's," or "How long have you had Parkinson's?" And, kind of put them off. So with that, who's to say that personality changes aren't something, or apparent, I'll say perceived personality changes, aren't a premonitory early non-motor symptom? Does that make sense?
And the other question is, what about previous injuries like head, like if you play football or anything, would that contribute to it too?
It can. Head injuries are you've all seen in the news media the emphasis on monitoring football players. We pull them out, and there's the chronic traumatic encephalopathy diagnosis that you've probably seen lay press articles about. And I remember something that sticks in my head from when I was a medical student is they said somebody gets a concussion where they get knocked out and there's loss of consciousness for 10 minutes or less. A third of those people can go back to their previous occupation, no worries. A third of people can go back, but at reduced capacity. And a third of people aren't able to go back. And depending on what angle and all kinds of things, it's definitely that impacts what happened. And of course, trying a head injury that happened years ago, it's hard to quantitate that, right? How do you measure? Well, it was at 30 degrees to the right and 20 degrees up from the line between your ears and your nose, And certainly there are some historical and celebrity patients with Parkinson's, Muhammad Ali being one, and actually his brother who engaged in boxing and did getting hit in the head during boxing, even if you're a successful boxer like Muhammad, did that somehow set something in motion. In general, head trauma is one of the things that we think may increase somebody's risk, but whether that's you need to have either 1 or 2 or 4 or 10 risk genes that there's that interaction. We don't yet know that, but we do see boxing, things like people that were working in and around agriculture seem to have a higher risk in general than somebody who wasn't. Now, is that because of pesticides? Possibly. Things like the Agent Orange, it's plausible that it impacts Parkinson's, and as you probably all know, if you were in country in Vietnam, you're sort of automatically assume that you were AO exposed and that contributed to your Parkinson's. Scientifically, I don't know that they've actually, but I think probably wisely, I don't know if this was their motivation or not, but it was probably a lot less expensive, and the money spent would be better in treating those patients than in trying to go back and litigate. No, it wasn't. Yeah. I think it was probably a better use of, okay, let's just assume that it was because it is biologically plausible, and we'll move forward with trying to optimize treatment.
I want to refer to the pre and post personality. I can give an anecdotal testimony that being introvert before Parkinson didn't make me extrovert after, and being unmotivated to do exercise before didn't make me more motivated to do exercise after. My question has to do with the complexity of different medical conditions at the same time as Parkinson, like diabetes, incontinence, sleep disorder, and things like that, or ADD. And the fact that sometimes I feel that medication for one thing may be detrimental for the other, even though the specific expert in each field say, no, 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 it's okay. But it seems like there's no overall way to balance one and the other. And the same thing about nutrition. If you list the things that are recommended and not recommended in nutrition for Parkinson, you're not supposed to have proteins with the levodopa, but you're supposed, for the diabetes, you have to have more protein and less of the carbs, and you get overweight, and you should not have too much food before sleep, but you can, it's such a complex
It's
thing.
dizzying.
It's dizzy, and I haven't met a nutritionist who could make sense to me with all these things. Thank you.
You've actually touched on one of my favorite topics, which is, we know that at least 70% of patients with Parkinson's will use supplements. I've looked into things like B12 deficiency, vitamin D deficiency, and there's one thing, for some conditions, I think you are correct. There may be medicines which may worsen Parkinson's motor symptoms. So people with depression, and say their depression was bad enough to where they had a psychotic depression, or they didn't have a good enough response to traditional, like SSRI kind of class of medicines. And so some of the, what they call atypical antipsychotics are added on. Most of the typical antipsychotics, the things that people use to treat schizophrenia, we know definitely worsen Parkinson's symptoms. And for the most part, if you get them in doses that are high enough, even the atypical antipsychotics, the newer ones, can worsen the motor symptoms of Parkinson's. And so the key is using those in as low a dose as possible. For things like diabetes, well, if your blood sugars are way out of whack, then that in of itself is going to amplify and make the Parkinson's symptoms harder to control. On the story behind protein, what happens is, and it's not always evident in the early stages of Parkinson's, and some people never seem to have this effect, but if they take their Parkinson's medication and then they eat a meal that's high in protein, the levodopa, the active ingredient in carbidopa-levodopa, which is kind of still our gold standard treatment for dopaminergic therapy, the levodopa is basically an amino acid. It's the raw material your brain uses to make dopamine. Well, when you break down protein, you eat it in your stomach, you break it down, the protein is interfering with it. It's competing to get absorbed across the gut into the bloodstream. And so Oftentimes people misconstrue and they say, oh, I need to cut back on my protein. It's not necessarily cutting back. It's trying to time it. I think doing the low protein during the day, higher protein at night kind of diets are just, it's a logistics nightmare. I mean, Radar O'Reilly from MASH couldn't sort it out. For most people. I'm not saying that there aren't people that can manage it, but I think your better approach is to try to, I say continuously snack, where that instead of having 3 larger meals, you might have 6 smaller snacks throughout the day. So your caloric intake is there. Your balance between your macronutrients, protein, fat, and carbs is there. And your micronutrients are there. The other thing that has to do with nutrition is that in order for carbidopa levodopa to get absorbed into the bloodstream, it's got to get out of the stomach. And we know that people with Parkinson's often have a delay in what we call gastric emptying. So you eat or drink something and it dumps from the stomach into the intestine. The intestine's where carbidopa in particular is absorbed. It's probably a little less delayed for liquids than with solids. So those of you who might have come to my clinic have probably heard me say, when you take your medicine, take it with a full glass of water or some kind of liquid, because the liquid is more likely to dump into the small intestine where it can then get absorbed faster than a solid meal. Now, early on, I tell people, take your medicine with foods so that it's a routine, right? Meals are like punctuation marks, and it's just easier to do that. As time goes on and people need to take their medicine at a strict 4-hour interval or a strict 3-hour interval, then they may benefit from timing of their medicine. And you're right, a lot of nutritionists, they don't have good ways of balancing these. And so I go back to, well, what have we proved is beneficial? Well, we do know that certain diets, like the Mediterranean diet, which as a general rule of thumb, the more colorful your meal is, the better off you are, right? And try to go, if you're going to eat fats, things like olive oil are better for you than the partially hydrogenated fats. And getting that balance, because if you cut back on your protein and you're not getting enough protein, then just like if you cut back on your fats, you burn fat and you lose fat. Well, if you cut back on your protein and you're not getting what your body actually needs to maintain muscle mass, you're going to burn your muscles and you're going to lose muscle mass. And you know, with the newer generations of medicines, it's becoming increasingly difficult. My husband was recently started on Ozempic, you know, the diabetes medication. And people are using it not just for diabetes, but for weight loss. He was talking to a physical therapist, and she said, well, I've noticed is if people don't do a weight training program, so if they're not like Mike and getting back in the gym, they tend to lose muscle mass on that medicine. So I think if you follow those general guidelines of, okay, let's get a balanced meal, and you can have the nutritionist do things like, if you keep a 3-day food diary where you write down everything you eat, you don't have to go to a nutritionist. There are lots of online things that will give you, okay, what's my mix of micro and micronutrients, vitamins and trace elements, and macro, fats, proteins, and carbs, that this diet that's my average diet is getting me. And where the nutritionist may be able to help you out is say, okay, you know, you probably, for your height and weight, you probably need a little more or a little less protein, and they can help you sort that out. but it's an ongoing educational process. The fads in terms of diets, who was the guy that did the paleo? Atkins, thank you. Yeah, those kinds of things I'd be a little cautious about unless I were doing them in the context of like a study where somebody's really carefully monitoring. Right. Yeah. So I know that's not a specific answer. That would be really nice. But you point out a tremendous challenge, and I think trying to keep everything in balance. I remember years ago, I talked to the Parkinson support group over at Wesley Woods at Emory, and I had my kids with me at the time, and I'm there talking about balancing, and my kids there balancing on one foot. But I think it's that everything in moderation. Does it mean you can't ever have ice cream? Well, I personally think ice cream's a calcium serving. So, but I can't have it every day, you know. And there are times where I realize, okay, I've reached that age where I'm menopausal. You know what? I think dairy really makes the hot flashes much worse. So, you know, I don't exclude ice cream, but I don't eat it every day. And I think the same thing is true with some of the dietary habits.
Well, just wanted to say, in response to what you said, we go to the Center for Movement Disorders, and there's a nutritionist there, Carol Lee Horner, who does a free class. I learned so much, and we didn't have a specific, you know, we didn't go in with a diet that we were on, but she taught us. Like, I thought I was knowledgeable. My friends all said I was knowledgeable, but after I took her class, I knew nothing. And she really, it's a very no-nonsense, very healthy diet, a Mediterranean diet, like you're talking about, of colorful foods. It is such a great course with 6 weeks, like an hour and a half each day. You are going to learn more than you ever thought you'd ever know. And I also wanted to say how disappointed that I am that my husband's doctor never mentioned diet, ever, 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 or the timing of the medication. You know, we tried that timing of the medication, I thought I would lose my mind. I mean,
That's what happens.
Okay, if you're 30 minutes later for, you know, because I mean, we don't live in a facility or anything. We don't eat at 7, 12, you know, and 6 every single day. And keeping that, you can't eat 2 hours before or 2 hours after, you can't eat this, you can't eat that.
It's a nightmare, isn't it?
It's a nightmare. I also just want to thank Mike and Jerry for your candor on the things that are not talked about in Parkinson's, the anxiety, depression, and, you know, thank you so much, because that's the stuff nobody talks about unless you have it.
Yeah, go ahead.
Time for one more question, I don't know.
Yes, we can do one more question, sure. And also, we will have another short question and answer after the research talks, so if you've got a burning question after that, we can take it then too, but go ahead.
First of all, I want to say thank you all for being here. Thank you for your service, your military service to our country, for your medical service to our country. 18 years Army, I'm in the reserve now, and I have a recently acquired brain injury, so I have tumor in the bone, so I'm like looking at the brain, like looking at it, I understand everything around the symptoms, right? Depression, anxiety, like beyond like anything that I could have imagined. And so I'm looking at it, and my question is there any research or treatment around psilocybin and Parkinson's as it relates to like brain function and restructure, and also in the veteran community?
I'm not aware of any specific in the veteran community right now, but if there were, it would be listed on, are you familiar with the website clinicaltrials.gov?
I'm not, so maybe.
Okay, so just like sort of in general, clinical trials where somebody is looking at it, whether it's investigating, might this be an opportunity that would be like a phase 1, 2 kind of trial, what they call it. Phase 3 is where, okay, there looks like there's some promise, and let's look at this in larger numbers of people with the disease or condition and see, is it safe and or effective. Phase 4 are where it's after the drug has been approved by the FDA for sale and marketing as a treatment for a specific disease or diseases. And in order nowadays to get a study published, it must be registered. There's clinicaltrials.gov, and there's another one overseas. And Dr. Vaughn, I see you hiding out. Can you help me remember what's the other registry? I always go to clinicaltrials.gov because it's U.S. and I'm egocentric in that way. That, hey, this is the U.S. But if you're looking for anywhere in the country a trial that is not the snake oil salesman selling stuff for whether it's brain injury or whatever, go to clinicaltrials.gov. You can search by like condition. It will have whether it's enrolling, not enrolling, if there were results. It will have contact information if you're interested. And so that would be probably the best source as to, is there anything actively ongoing right now?
Okay, thank you so much. And in the interest of time, we're going to go ahead and move on to the next section of the program. But thank you so much, Dr. Evatt, Mike, and Jerry, for sharing and answering our questions and talking about your experiences.